Hello everyone, this is Vicki and I will be teaching the shock class. So shock is not a disease or an illness, but rather it's a syndrome that can affect all body systems. It can occur in response to any disease state, illness, or injury. So I like to call it an equal opportunity employer. Shock can have a variety of underlying causes, and the seriousness is that it can result in cellular or organ death and ultimately the death of the client. So nurses must understand the underlying mechanisms of shock, the pathophysiology, and the body's response. There will be quite a bit of pathophysiology in this introductory PowerPoint. And as always, you will not be tested on the pathophysiology, but you do need to have a good understanding of it to go forward and understand the nursing care of a client in shock. Much of the care of the client in shock takes place in critical care areas, but early stages are seen in the field and in non-critical care areas. So it's important for the nurse to recognize early and subtle symptoms of shock. The onset may be rapid or it may be insidious, and therefore nurses must have excellent assessment skills and respond to shock immediately if the client is going to recover. Now, recovery of the client is dependent on the client's pre-morbid state of health. In other words, the state of health they were in before the state of shock. There are 4 voiceovers for this class. This is the first one, and it's meant to form a foundation for understanding the others. Remember, there's a lot of pathophysiology here. Some of it should be a review, and you should recognize it. But it's a very interesting phenomenon, and I think that once you get into it, you'll enjoy learning about it. I've tried to demystify the book a little bit, and I hope that these series of PowerPoints help you with that. One last note, the book does speak to 4 different types of shock. We are only going to be concerned with 3. So we are not going to work with obstructive shock. Later in a subsequent PowerPoint, I will talk about abdominal compartment syndrome, which is an example of obstructive shock, but we're not going to talk about it any further than that. So I think that's it, and I will see you in class.
I like to start my shock lecture with this question because it really drives home a foundational piece of information about shock. So a client is treated in the ED for shock. The nurse knows that shock is a clinical syndrome in which cellular dysfunction and organ failure occur primarily as a result of A. Hypotension, B. Loss of blood, C. Severe infection, and D. Ineffective tissue perfusion. So take a minute and think about that. So the answer is D. Ineffective tissue perfusion. You may have seen that down below in my notes, but it was good if you had a moment to think about it. So in your McKinney reading is this statement, which I think is very important. Shock is an acute, complex, unstable physiologic state of inadequate oxygen delivery to the tissues. Decreased tissue perfusion leads to a cascade of physiologic consequences and, if prolonged, irreversible tissue and organ damage. I like that statement from McKinney because I think it really sums up the cause and the response that the body has to ineffective tissue perfusion in the state of shock. Now that we know that ineffective tissue perfusion is a problem in shock, let's look at what is needed in the body for effective tissue perfusion. Well, the body needs three things. Number one, it needs a sufficient blood volume. If there is a great loss of blood, then the heart, no matter how hard it works, is not going to be able to adequately perfuse all the way down to the toes. If there's something wrong with the cardiac pump, if it's not pumping well or efficiently, for example in heart failure, again, the body isn't going to be able to perfuse down to the toes and up to the brain. The third thing the body needs is effective vasculature. So it needs something called peripheral resistance. And this is how the blood gets back from the toes back to the heart. So this is venous return, or another word that you're familiar with is preload, the process of getting that blood back to the heart. So we can measure this, and we can measure it with something called the mean arterial pressure. That's a product of the cardiac output times that peripheral resistance. So how much the heart is putting out multiplied by the amount of resistance it takes to get the blood back to the heart. In order for a client to be effectively perfused, they need to have a mean arterial pressure that exceeds 65 millimeters of mercury. So in order to get oxygen and nutrients out to all the cells of the body, the client must have an MAP greater than 65. Another value that you may look for in your reading is the central venous oximetry, which must also be greater than 70.
I just wanted to add that your book does not discuss the mean arterial pressure. This is the average of the diastolic and systolic pressures, and it is measured on an arterial line, and it is missing from your chapter in your text. And I think it's a really important measure to know and understand with regards to shock. And I think your book goes into many other different measures, but for a graduate RN, I think this is important information for you to have. And so when we measure effective tissue perfusion, we are going to primarily talk about the mean arterial pressure. We may also talk about the SVO2, or the central venous oximetry.
Here are the classifications of shock that we will be talking about in this class. So you can read my notes below. They're fairly extensive, and we will talk more about each type of shock as we move forward. But I'd like to make a connection here between the classifications or types of shock and what is needed for effective tissue perfusion. So hypovolemic shock is a loss of sufficient blood volume. In that way, it goes back to the body needing a sufficient blood volume for effective tissue perfusion. Cardiogenic shock occurs when the heart's ability to contract and pump is impaired and there's an inadequate supply of oxygen to the heart. So that takes us back to the body needing an adequate cardiac pump. And finally, circulatory, or another name that you may hear is distributive shock, is when the blood vessels relax or dilate and don't allow for that peripheral resistance that's needed to get the blood returned to the heart. So you can see here how the different classifications of shock are dependent or work back to what is needed for effective tissue perfusion. We're going to talk in a minute about the different stages of shock. But before we can do that, it's important to understand the body's compensatory mechanisms in shock. So remember, the beautiful thing about the human body is that it has a built-in ability to compensate to insult or injury. So if you put this slide in slideshow mode, it's a little bit bigger and you can see it a little bit better. But then again, your eyes probably aren't as bad as mine. So here's what happens in shock. Very often one of the first things you see is the blood pressure drop. And a couple key things to think about what's going on in the body. The sympathetic nervous system creates a hypermetabolic state and an inflammatory response to compensate. The adrenal medulla releases epinephrine and norepinephrine, which increases the heart rate and causes vasoconstriction to help restore that blood pressure. The kidneys release renin, converting angiotensin 1 to angiotensin 2. And you'll remember from our heart failure lecture that angiotensin 2 is a very powerful vasoconstrictor, which can cause increased peripheral resistance. The adrenal cortex releases aldosterone so that sodium and water is retained. Increasing serum sodium can stimulate the antidiuretic hormone, ADH, which in turn can cause the kidneys to retain water. This raises the blood volume. So you can really see here the pathophysiology and the mechanisms of compensation that are going on in shock. Here are the stages of shock. The goal of care in the client with shock is to return the client to homeostasis and to prevent cellular and organ death and ultimately the death of the client. So remember that I said assessment is key and understanding pathophysiology is very important so that the nurse can take all of the assessment data with the understanding of what's happening in the body and put all the pieces together for quick identification that a client is in shock and to be able to enact the proper care and treatment depending on the stage that the client is in. The body has a cellular response to shock, and it begins there in the cells when they're deprived of oxygen. Remember, this is an issue of ineffective tissue perfusion. In order for the cells to produce energy once the body is in shock, they must do that through anaerobic metabolism, which you will remember is low energy and creates a cellular state of acidosis. In that state, the cell swells and the membrane becomes more permeable, allowing fluids and electrolytes to move in and out of the cell. The sodium-potassium pump is then impaired, and lactic acid begins to build up at the cellular level. Also important to know for your assessment, the other thing that's happening is that glycogen, which you know is stored in the liver, is now called upon and converted to glucose in an attempt to compensate for the cell's metabolic needs. So you may see hyperglycemia as a result. The glycogen stores then can be depleted. So it's important to think about what is going on at that cellular level and put those pieces together with what you're seeing clinically in your assessment.
I'd like to quickly add two things about this slide with reference to your Hoffman book. So Hoffman talks about an initial stage of shock
in addition to compensatory, progressive, and irreversible. We are going to not concentrate much on an initial stage, so it didn't make the slide, but I did write down below that the initial stage is simply the cellular's first response to shock. Cells are deprived of oxygen, and sometimes we see clinical manifestations, but most times we don't. But even though we don't see it, know that damage is beginning at the cellular level. One of the things that is happening at the cellular level that I do like that your book talks about is that there's a buildup of lactic acid. And I did put a normal value down below for lactate levels. And so this is something new that I wanted to add to this lecture. If a person is in shock, then their lactate levels will increase beyond the normal level. And if they are successfully treated and shock is reversed, we should see those levels begin to decline again.
In your Lewis text on page 1639, there is a chart that outlines the stages of shock, and it gives some criteria for each stage. This is not my favorite chart because it's not as specific as some others that I have seen, but because people are individuals and criteria can be different, um, the more specific criteria that I put in these slides are a good place to start. So for the purpose of us coming together in class and discussing case studies and for testing, I would like you to refer to the criteria on these slides in addition to the criteria in the chart in your book. So starting with the compensatory stage, remember that your goal through assessment is to identify these symptoms early as a problem of shock. So in the compensatory stage, cardiac function is typically maintained. Now your book takes a little bit of a backdoor approach to this, and so I'll try to clear this up. The book says that initially the blood pressure drops, and it may. But the compensatory mechanisms of the body work to restore it, at least for a short time, back to its normal blood pressure. The heart rate, however, may be elevated, and I use the criteria of over 100 as a starting point. And the reason that it may be elevated is because the heart is working harder because the sympathetic nervous system is causing vasoconstriction. In the respiratory system, we see some changes as well. Remember that metabolic acidosis is first occurring only at the cellular level. So the body compensates for that in response by blowing off CO2. So you're going to see an increase in the respiratory rate and a respiratory alkalosis initially. The flight or fight syndrome or response kicks in due to the release of epinephrine and norepinephrine. And this causes the body to shunt blood away from the skin, the kidneys, and the GI tract. And the purpose is to conserve blood flow to more important places like the heart and the brain. So, what you may see as a result with your assessment findings is cool and clammy skin, decreased urine output, and hypoactive bowel sounds. At this stage, as a result, aldosterone and antidiuretic hormone are released, and in turn, this causes a decrease in urine output. Also, due to this alkalotic state, you may notice confusion in your client. So goals are to identify symptoms and treat the client early, and most important, to prevent progression to the next stage. You want to treat the underlying causes of shock now that you have identified them. It's not unusual in this stage to see loss of consciousness, a narrowing pulse pressure, which is the difference between the systolic and the diastolic numbers. When they get closer and closer together, we call that a narrowing pulse pressure, meaning that there's little rest in between contractions. Even though the blood pressure is probably being maintained for this short time. You're also likely to see a decreased MAP, mean arterial pressure, and an increase in serum sodium and glucose levels. And if you think about the body's compensatory response, you'll understand why you'll have those findings. So goals are to, number one, prevent progression, monitor tissue perfusion. That's how you're going to know if shock is progressing. Reduce the anxiety of the client and promote their safety. And I think that's it for this stage.
Please disregard my reference to the Lewis text. I didn't want to re-narrate this whole slide because everything else in that narration was really in good shape. I did put below the page numbers of a similar chart in Hoffman, and I would say that I actually do like this chart, and it follows pretty closely. So the signs and symptoms on this slide and the next couple just go into a little more detail than what's in your Hoffman text.
During the progressive stage, the body's organs begin to suffer from hypoperfusion, that ineffective tissue perfusion, and they begin to decompensate. So now we will see the mechanisms that regulate the blood pressure are no longer able to compensate. So the blood pressure and the mean arterial pressure decrease. That pulse pressure, the number subtracting diastolic from systolic blood pressure, also narrows. The number decreases and we say that it narrows. The systolic blood pressure is generally less than 90, or a decrease of 40 millimeters of mercury from that client's baseline systolic pressure. The heart rate is now above 150. So you can really see that compensation is no longer holding this client together. The heart becomes ischemic and it begins to lead to failure of the cardiac pump. Fluid leaks into the interstitial spaces, causing edema, and also that in turn causes decreased venous return. An inflammatory response kicks in and the body activates coagulation. Later in this lecture we'll talk about DIC. This is the opportunity for DIC to occur. Bleeding times are prolonged. DIC is a phenomenon of clotting and bleeding. Therefore you may see things like petechiae, which I've provided a picture for you. Inadequate perfusion of the heart can lead to dysrhythmias and ischemia. Your BNP levels and troponin levels may increase as a result. In the respiratory system, you can see a decreased blood flow causing hypoxia, CO2 levels to increase, and pulmonary edema. The lungs begin to fail, and mechanical ventilation may be required at this time. Due to the ineffective tissue perfusion, circulation is affected and you may see mottled skin. That's the picture underneath the petechiae. Urine output, as the mean arterial pressure falls, the glomerular filtration rate cannot be maintained and acute renal failure may occur. You may see the BUN and the creatinine increase as a result. Mental status further deteriorates because there's decreased cerebral perfusion and hypoxia, and you see a prolonged state of lethargy. Metabolic acidosis is no longer at the cellular level in this stage. It is now throughout the body. Your goals and interventions are to monitor the hemodynamic and cardiac function. You'll be in this stage administering medications and fluids. You will provide collaborative care. Most likely at this point you'll be in intensive care working with other health professionals. You want to prevent complications such as infection that will further insult the body's ability to survive this state. And you want to promote rest and comfort, preventing extremes of temperature, which goes back to the stress on the body from the increased metabolic rate. The family at this point requires your support as well. The irreversible or the refractory stage is the final stage of shock. This is not where you want your client to be. However, depending on the severity of the shock or their premorbid health, this stage may occur in your client. In this stage, organ damage is severe. The patient does not respond to treatment and cannot survive. The blood pressure remains low, and it requires pharmacologic intervention to maintain it at all. So that's really the key of this stage, that both the cardiac and the respiratory systems require mechanical and or pharmacologic support to continue to function. The liver may fail, which may result in jaundice of the skin. Renal function fails, and the client may be without urine output. Generally, the client is unconscious in this stage and in a profound state of metabolic acidosis. The client is often classified as having multiple organ dysfunction syndrome, or MODS. This begins with the failure of 1 to 3 organs and results in complete organ failure. Your nursing care in this stage is similar to the progressive stage. The judgment that shock is irreversible is made only in retrospect, so you will continue to care for your client in the same manner. But you will begin to provide end-of-life care and psychological care of the client and the family, preparing them for that. Multiple organ dysfunction syndrome, or MODS, is caused by inadequate tissue perfusion that begins to cause organ death. It usually begins in the lungs and progresses to other organs. It's an ominous sign and very often is fatal, and hospice care may be appropriate for the client with MODS. It occurs often in clients with septic shock and the elderly. Malnutrition and comorbidities also increase the risk. So this is a complication of shock that is generally present as the client moves through all the stages and is in that irreversible stage when tissue perfusion is extremely ineffective and the body can no longer compensate, and the medications and the fluids you're providing are not maintaining the client either, and their organs are dying as a result. MODS usually begins in the lungs. It can start out insidiously with dyspnea that progresses to respiratory failure requiring intubation. After the lungs, we can see mods advance to the cardiovascular system, hepatic, GI, renal, immune, and the central nervous system.